Okay, we're going to begin now. We want to thank you all for joining us for the Truth About Hormone Therapy. It is the fourth Menopause Talk in our Menopause Talk series presented by Let's Talk Menopause. Let's Talk Menopause is a national nonprofit whose purpose is to change the conversation around menopause so women get the information they need and the healthcare they deserve. I am Jessica Levin. I am the webinar director for Let's Talk Menopause. I want to just briefly thank Revel for being a continuous partner to us and Alloy for sponsoring our Menopause Talk series. We are thrilled to be joined today by incredible leaders and speakers, Barbara Hannah Grufferman and the dynamic duo, Dr. Lila and Dr. Margaret Nachtigall. Before I introduce Barbara, and then she will introduce Dr. Lila and Dr. Margaret Nachtigall, just a few housekeeping items. The first one is the question and answer section of Zoom will be open. It is unlikely we are going to get to answer your questions only because this topic is very important and very complex, and the depth of knowledge and experience our speakers have is unparalleled, and we want to make sure you really can benefit from that to the fullest. So, but please leave your questions anyway, because in one way or another, we will answer them, whether it's through a subsequent newsletter or Menopause Talk. We are closing off the chat, so definitely express yourself in the Q&As. We will end 2 to 3 minutes early so we can post the survey for you, which is a brief survey. We just want your feedback so we can continue to be responsive to you. One other brief thing, this Menopause Talk is for information and purposes only. We do not advocate for a specific position. That's really for you and your healthcare practitioners to determine the best treatment for you on a case-by-case basis. So thank you so much. And I'm going to briefly introduce Barbara. We are thrilled that she agreed to be our host for this Menopause Talk. Barbara is, she is a leader in positive aging, and she is a speaker and a writer and an author and a media personality and a consultant on health and wellness and careers and sex and nutrition and healthy aging. And her highly regarded 2010 book was The Best of Everything After 50, The Expert Guide to Style, Sex, Health, Money, and More. And her second book was Love Your Age, The Small Step Solution to a Better, Longer, Happier Life. And more recently, Barbara, in partnership with Dr. Margaret Nachtigall, launched a weekly newsletter called the Menopause Cheat Sheet. And soon enough, she's going to be launching a new podcast called Gruff Talk. So I am going to turn it over to Barbara, and thank you all so much for joining us.
Thank you, everyone. Thank you, Jessica, for that lovely introduction. And thank you, everyone, for joining us today, taking time out of your very busy lives to spend a little bit of time with us. And much gratitude goes to the Let's Talk Menopause team for putting on these talks so that we can talk about something that happens to more than half the world's population, menopause. Yep, we need to talk about it more, as we all know. I am honored to introduce our two panelists today. These extraordinary women are women I've known for almost 25 years, and their stature in the medical field has grown exponentially over time. They are considered the go-to experts in all things women's health related, fertility, hormones, menopause, and so much more. And, you know, this weekend, I saw an article, it was very interesting, in the Daily Mail and some other places, that Gwyneth Paltrow, on the cutting edge of anything women's health, right? Maybe. And she is looking for a menopause mentor. So I say, if Gwyneth, if you're listening in, please go no further than these two women. So let me introduce them, please. Dr. Lila Nachtigall is one of the world's leading reproductive endocrinologists and widely recognized for pioneering medical research on hormone therapy, estrogen, and menopause. She has authored over 500 articles, written 3 books and lectures around the world focusing on women's health. Dr. Lila is currently a professor of obstetrics, I always stumble on that word, and gynecology at the NYU School of Medicine, and presides as director of the Women's Wellness Center at NYU Langone Health. Among her many roles, she has served as past president of the North American Menopause Society, known as NAMS. Dr. Lila also founded the Foundation for Women's Wellness, where she currently serves as chair of the board of directors. Welcome, Dr. Lila. And Dr. Margaret Nachtigall is a board certified OBGYN and reproductive endocrinologist and a clinical associate professor in the department of, there it is again, obstetrics and gynecology at NYU Langone Health. She holds a faculty position in the Division of Reproductive Endocrinology and many leadership roles in the medical school and residency training program. She has an active patient clinical practice in reproductive endocrinology with expertise and research experience in menopause, polycystic ovarian syndrome, and infertility. Dr. Margaret's commitment to teaching and educating others is unparalleled. This is reflected, among other things, by her recent receipt of the AOA, Medical Honor Society Outstanding Teacher Award, which is really incredible and a very big deal. Her extensive speaking engagement, she's been on television and publications, serving as co-founder and medical director of, yes, Menopause Chi-Chi, which means I work with her very, very closely. And she is a founding member of the North American Menopause Society as well. Welcome, Dr. Margaret. Now, you may have noticed that they share the same last name because, yep, you guessed it, Dr. Lila is the very proud mama of Dr. Margaret, and Dr. Margaret is the very proud daughter of Dr. Lila. Welcome both.
Thank you, Barbara.
Okay, let's get right to it. Hormone therapy, HT, or hormone replacement therapy, HRT, whichever way you want to call it, was considered the gold standard of treatment for women who were suffering through the most common symptoms of menopause: hot flashes, mood swings, sleepless nights, and the like. And then all that changed literally overnight. In July of 2002, 20 years ago, a big study came out, and before it even had the chance to land in the medical journal it was supposed to be in, published in, the general media got a hold of it, and there was a frenzy, creating all kinds of havoc and panic that we had never seen before. So what happened literally overnight? Women stopped taking HT and doctors stopped prescribing it. Now, many experts remember this, of course, because it was a very big deal in the medical field. But what they remember most about it was the media frenzy, because it just stopped everyone from taking HT and then created this whole generation of women who suffered a lot more than they should have. Because it's the 20th anniversary, there are a lot more articles out about it right now. And I came across one in a medical journal this week, and there was a great quote I want to share with you. Dr. Nanette Santoro, who is a professor at the University of Colorado School of Medicine, who is going to be on a panel in a future Let's Talk Menopause event, so keep an eye out for that, was recently quoted as saying, "The findings made headlines for the barely over a statistically significant increase in heart disease and the barely under statistically significant increase in breast cancer. All the public saw," she said, "was that HT caused heart disease and gave you breast cancer. 75% of HT prescriptions and medications were thrown away." Today, we're going to talk about that study. We're going to talk about the key findings and why they cause such a panic among patients and physicians. But more importantly, we're going to talk about how is HT viewed today? What does the science say? What do the experts say? And we're going to cover a few of the biggest myths around HT and bust a few of them as well. So let's get right to it. All right, Dr. Lila, we're going to start with you. Let's start at the very beginning of this discussion. So there was a media frenzy when the study came out in 2002. Why is that? What happened? But first tell us, how was HT viewed before the study came out? And then give us some of the key findings.
I have to say that the Women's Health Initiative was an unbelievable endeavor. There's never been a prospective study starting from ground zero and following women for that many years of 20,000 women, 1,000 women in the treatment group and 1,000 women in the control placebo group. And there were many flaws in the study, but there had to be flaws on an ambitious group like this. It was a great idea to try to get the science of the hormones, the good, the bad, the benefits, the risks. And up until that time, after a book that said every woman needs estrogen, which isn't true. I think the majority of women need it, but it's very individual, which we really have learned over and over. And I think up until the time of this study, many OBGYN doctors saw their patients go into menopause and without discussing the risks, the benefits, said, you're in menopause, take estrogen. And I think it was overused. However, when they did start the study, they made many mistakes. And some of them they couldn't help because they didn't have the information. But the biggest mistake was to give a combination therapy to the treated women, which was estrogen, which had been around by then for 50 years, and combined with a synthetic progestin that turned out not to be the best choice. But the wrong thing they did was to give it to them every single day. And it was a high dose, it was synthetic, and it was given all the time. In the normal cycle, you only get progestin for a short time of the month. And of course, a different natural progesterone. They also made a big mistake in that they didn't take any woman under 50. And they did it for a good reason. We knew that estrogen fixed hot flushes. We knew that for a very long time. So they didn't want women in the study who had hot flushes, so they ignored the women under 50. And they thought if we take women with hot flushes, they'll know who's on placebo and who's on treatment. So you could kind of see that. But normally, more than half the women we treat are under 50. This is the time that they have the worst symptoms, and it turns out to be the time when it's good to start, and we'll go into that in more detail. So one, they gave combination estrogen progestin every day. Two, they ended up taking much older women. 21% of the 1,000 women on treatment were over age 70 and had never been on estrogen before. And most of them didn't need estrogen anymore or at that time. And those of us who really work in the field, way before the WHI, almost never started a woman at 70 or over. We may continue estrogen from a younger time, but we never started at that age. They also ended up, and we don't know why, with an overweight population. Well, maybe that's the trend in the whole country at any case, but the average weight was way above the average weight of women in the United States. And that, of course, put them at higher risk for heart disease.
That's really interesting. But what were some of the key findings of the study, if you could summarize? And also, why did it cause such a panic that literally, as Dr. Santoro wrote, almost 75% of the medicines went out the window? Why is that?
I think it was misinterpreted. I think that was the biggest flaw. And as you mentioned, before it even got in the medical journal with all the science and all the numbers, it got into the media where they said increase in heart disease, increase in breast cancer. The increase in breast cancer was not statistically significant. And in science, especially in such a large study, we throw out results that are not statistically significant. And as Dr. Santoro correctly said, the heart disease just barely made it. It was 23 more women per 10,000. That is,
as she said, barely statistically meaningful.
9,980 women did not get heart disease and did well.
Exactly.
Anyway, it's been repudiated since over the 20 years. Over 100.
Right, we're going to get to that actually now with our first myth, which we're going to go into. Now that we've got the background of what happened with the study, that HT was the gold standard, and then the study came out and all this mayhem ensued, let's shift gears and take a deep dive into some of those big myths that have really been going around for the last 20 years, especially as it relates to the study. So Dr. Lila, back to you again. As you were just saying, it has some validity, right? But it's all very confusing to all of us because there were flaws, some of which you've already mentioned. And but how is the study viewed today, 20 years after its publication?
Well, those who really study this and really work in the field of menopause have come a long way. And all these myths have been changed and corrected, I should say. And but it's been repudiated mainly by the original authors of the study. One of the first authors, Joanne Manson, who at the end of the study actually said all women should go off estrogen in her misinterpretation. She has changed that 100 times, and in very good articles in peer-reviewed journals has now shown that the benefits of estrogen outweigh the risks. And really, they have taught us many things if we really get away from the hoopla and look at the science. It's very helpful in individualizing therapy for each woman. We can see what the problems are, and we'll go into that. And one of the biggest problems is that the everyday progestin, and Dr. Margaret's going to go in this in detail, was the negative. In many instances, for example, the heart disease issue, it was the progestin that was the bad guy. So, and we learned that by a second part of the study, which didn't come out for 5 years later, which were women who didn't have a uterus, weren't on the progestin, and did fabulously well. So we'll go into all this, but those who really follow the scientific literature have, over the 20 years, learned who should not take estrogen, and that the benefits outweigh the risks in the vast majority of women. And so we've changed our minds. Unfortunately, there are still doctors who are stuck in 20 years ago. And I get to hear that all the time, where women come in and say,
and many women too, Dr. Lila, many women too, I'm sure both of our doctors today have patients who are concerned about that. But let's go to myth number 2. And Dr. Margaret, we're going to go to you for this. Myth is hormone estrogen therapy causes breast cancer. Dr. Margaret, can you explain why this is a myth?
So just as we just discussed, one of the benefits from the WHI is that now we have a 12-year follow-up, we have a 20-year follow-up. And so now we can look back and we can see what the findings have shown by looking at different aspects of the study. And one of the areas, which has also, there have been other studies as well, can show that there was a group of patients that got estrogen alone. These are individuals that do not have a uterus. They didn't have a uterus when they started. So they didn't need to take progesterone. So in that group of people, they were taking estrogen alone. And lo and behold, what has been shown is that that group, the patients that were taking estrogen, had a 23% reduction in the incidence of breast cancer, and actually had over a 40% reduction in mortality from breast cancer. I have a slide to make this a little clearer, if we could put that up. So what you're looking at here is the overall results from the WHI that is now looked back on, and over, this is, I think, after 12 years. So the bottom graph, at the bottom of the arrow, you're seeing years from starting estrogen. On the y-axis, it is the incidence or the amount of breast cancer. So one thing you can notice is that all four lines are moving in the upward direction. And that's because the incidence of breast cancer increases with age no matter what. That's the way it is. The older you are, the higher the chance of developing breast cancer. And now the incidence of breast cancer in the United States is between 1 in 8 and 1 in 9 people will develop breast cancer throughout their lives. So now let's look at the graph. What you're seeing is on the bottom line, the purple line, what that is showing is the incidence of breast cancer in patients that were taking estrogen alone. Their control group is a red line. And what you see is that as time goes on, the patients that were taking estrogen actually had fewer breast cancers than those that were taking no hormones at all. However, the top line is a blue line. That line is the combination of estrogen plus progesterone. And these are for patients that have a uterus. Their control is the green. Fortunately, the green and the red match because those are two groups of individuals that are not taking any hormones. They're taking just the control. So what you can see is the first 5 years on hormone therapy, there wasn't a significant difference. As time went on, there is a slight increase in the amount of breast cancers that are developed in the patients that are taking combination. But estrogen alone did not cause breast cancer. You can take the slide away. Thank you. So what this means is that if you take estrogen alone, that's not going to take a normal cell and turn it into a breast cancer cell. However, if you have an existing breast cancer cell, estrogen will feed that cell and will make it grow bigger and faster. So what that tells us is that for the majority of people who do not have any breast cancer cells in them, if they take estrogen, that won't cause breast cancer. However, if there is a cell, then it could potentially increase breast cancer.
So, Dr. Margaret, what about progesterone? Like, explain that to us. And why do most women have to take progesterone with the estrogen? Help us out.
I really wish we didn't have to take progesterone, is my answer. The reason we need progesterone is we need something to balance the estrogen. So in the normal menstrual cycle, estrogen has its effect all over the body. But one of the things that it does is it binds to receptors in the uterus, and it causes the lining of the uterus, which is called the endometrium, to proliferate, to get bigger and bigger and bigger. And this is great during the menstrual cycle because we're preparing the endometrium for a potential pregnancy. However, when we give estrogen in menopause, if there were no progesterone around, the endometrium would just continue to grow and grow and grow. And eventually, in years and years and years of giving estrogen with no progesterone, it could develop into a hyperplastic or even an endometrial cancer. But if you give progesterone, that will stabilize the endometrium. That will keep it nice and safe. And so progesterone is given to prevent endometrial cancer. That is the reason that we give it. Now, when estrogen is combined with progesterone in the study, they showed a very small increase in breast cancer. So the total number was 20 new cases in 10,000 women after 13 years. So it was a small increase, about 1 in 500 women, but it was an increase. Now, if we had a better agent, we used to have an anti-estrogen, which was able to be used that could balance the endometrium and prevent endometrial cancer. But right now, progesterone is our best bet. So what,
Dr. Margaret, I'm curious, what happened to that anti-estrogen?
Right now, it's taken off the market temporarily for a packaging issue. But we look forward to having that back, or have something else that's invented, a new kind of anti-estrogen that could benefit the lining of the uterus. So patients that don't have uteri don't need to take progesterone. Those are people that can take estrogen alone. And so now what we do is we try to look for other ways. Instead of using the progesterone that was used in the WHI study, we try to use other kinds of progesterone for as short a time as will benefit the lining of the uterus, but not long enough to cause other negative effects. And progesterone can sometimes have some negative effects like mood changes and other things that we probably would love not to have it on.
Myth number 3, Dr. Lila, I'm coming back to you with this. You should never take HT if you have a relative who has had breast cancer. Can you please help us out on this one? What is your thought on that myth?
Well, I think it's wrong. It's a myth and it's wrong. And Dr. Margaret just told you, unfortunately, 1 in 9 women get breast cancer. It's incredibly high incidence. It's almost a variant of normal. So if you're in a room with 9 women, 1 of you is going to get breast cancer. If you go by having a relative, everybody has a relative. You're going to have a cousin or a second cousin or an aunt that had breast cancer. So we don't use that. However, if you have a primary relative, that would be a sister or a mother who really shares your genes, it pays to make sure that you don't have a genetic propensity. And the reason for that is not that you can't go on estrogen, but that you're monitored more carefully. And the other issue is that some of the genetics have negative receptors for estrogen. Dr. Margaret told you that if you had a cell that was pre-malignant but abnormal in that it had estrogen positive receptors, if you took estrogen, you could make that grow. You would not make a normal breast cell grow ever with estrogen. But there are genetics where they have negative estrogen receptors. And if you find out you have that, for example, BRCA1, 95% of those women who get breast cancer get estrogen receptor negative breast cancer. And there's no problem with them having estrogen. It actually may be helpful for them. So it isn't true. Don't worry about your relatives. You should give that history so we can look into what's important.
Again, another great example of having a really terrific healthcare provider as your partner and individualized medicine, which we will continue to talk about. Myth number 4, Dr. Margaret, back to you on this one. It is a double header. It's 2-parter. Vaginal estrogen increases the risk of breast cancer, part 1, and you should never take vaginal estrogen if you have or have had breast cancer. Could you address that, please?
So, yes. So first of all, there's a big difference between systemic hormone therapy that's going to go all over the body compared with vaginal estrogen therapy. So they're very different. And for the biggest difference is that for systemic treatment, as we just discussed, we need to take some progesterone. However, for vaginal estrogen, Vaginal estrogen is just going locally into the vagina. And by the way, it can be incredibly helpful. And there's almost no one that can't take vaginal estrogen, although there are people that cannot take systemic estrogen. So in vaginal estrogen, we don't need progesterone. It can be given just locally into the vagina. And so there's no need for progesterone for the most part. Occasionally there is someone that needs a little bit who is absorbing it, but for the most part, it's not absorbed. So the second part of that is, could someone who has breast cancer take vaginal estrogen? So if someone has estrogen receptor positive breast cancer, I would not give them systemic estrogen treatment for the reasons that we discussed. However, if they have been treated for their breast cancer and have vaginal dryness after that, what I usually do is to suggest using some over-the-counter products first. And if that is not alleviate the discomfort, then you can move into a vaginal estrogen in a tiny, tiny, tiny dose, because it's not going to get absorbed systemically. It's just going to be local into the vagina. Now, there are some people who are taking aromatase inhibitors, which are medications that are given to postmenopausal women who have breast cancer that are estrogen receptor positive, to eliminate or lower the amount of estrogen that they have. And for those individuals, I usually don't give vaginal estrogen. And again, this is, driving home the point again and again, why it's so individualized, the treatment and the care for each person. But one of the other benefits of vaginal estrogen, and we'll get into the timing of estrogen and when to start hormones, is that for vaginal estrogen, even if you haven't been exposed to estrogen for years, it's okay to begin some vaginal estrogen, because again, it's going to be local treatment, local into the vagina, into the walls of the vagina, and it can really reverse the vaginal dryness and can really eliminate the itching, the burning, the sandpaper-like feel, bring the collagen back, make the tissue more elastic, and really improve the vaginal dryness.
Yeah, and this is so important for women to understand, because as we know, when we write about it a great deal in Menopause Cheat Sheet, is that vaginal health is very tricky, because you may have those temporary symptoms like hot flashes, which eventually will go away, although maybe will take longer than you'd like. But vaginal dryness, unless, as you taught me this, unless treated, will only get worse. So this is really very important information for everyone. Dr. Margaret, before we move on to the next myth, can you just summarize for us, like, who really should not be taking hormone therapy? And maybe give us some ideas as to what are some of the options out there. I mean, you mentioned, of course,
right.
Vaginal estrogen, local estrogen, but what else is there, and who really should not take hormone therapy?
Right. So the people that really shouldn't take hormone therapy, one is people that have estrogen receptor positive tumors of any kind, whether it's breast or another kind. One person I saw asked about endometrial cancer, which is often estrogen receptor positive. That would be a case-by-case basis, because in that case, usually the uterus is removed. And so you would assume that the endometrial cells are gone, but that would be a case-by-case basis. So I would say that anyone that has estrogen receptor positive tumor should not take estrogen. And then there's any type of irregular bleeding. Sometimes people are having unexplained bleeding, vaginal bleeding. That would be a case where I would be hesitant and maybe wait until we've explained the bleeding before administering estrogen. And then the other category are people that are at a very high risk for clotting disorders. So people that have genetic mutations that make them very high risk for clotting, or people who have had previous pulmonary emboli. Those people are special case scenarios where we definitely would be have some reservation to starting estrogen, but again, it's an individual, every case is an individual decision. But those 3 examples are times where I would be a bit wary.
And also age comes into play as well. I mean, after you're a certain age, probably, which actually leads me to my next myth, which I'm going to put to Dr. Lila, myth number 5. You always should take hormone therapy for the least amount of time. Dr. Lila, is there an ideal time to begin, to end, how long? And, is age a factor in this as well as to when you begin HT?
So it is a funny myth. It's almost silly because people have interpreted what the FDA originally said. And what they originally said is that women should take hormones for the least time that meets their therapeutic goals. In other words, only take it when you need it. So for example, if you're taking it for prevention of bone loss, which is still a very important reason, you might have to take it for 10 years or more. And also, we're really recommending, all the organizations who may differ in other factors agree that women who have premature ovarian failure or premature ovarian insufficiency, and it's really like an early menopause, those women should be treated all the time unless there's an absolute contraindication. And more what we've seen is starting early at the time of menopause is very important and works well. One of the things we have learned from the Women's Health Initiative is more than 10 years after the menopause, if you haven't started it before, is not a good time to take it. I think Dr. Margaret's going to go into that after, but we know that about heart issues, definitely. And about bone, the greatest percentage of bone loss occurs the first 5 years after menopause occurs, after the last period. So for every woman, even if she never loses a lot of bone, a great percentage is early on. So that's a great time to treat. So in general, we're better off. Certainly we want to treat before 9 years after menopause. We learned that from the WHI. But I think the best treatment is probably the first 3 years after menopause. And if you're having hot flushes, it's a sign that a lot of other bad things are going on. So those should be treated right away.
Thank you for that. And thank you for bringing up bone health. We will address that in another myth a little bit later on. And you all know that bone health is super important to me. I broke my arm, and anyway, that was my bone health journey. It's a long story for another time. Dr. Margaret, myth number 6. Okay. No one should take HT unless their suffering is unbearable. Now, we do know there's a range. A lot of women just go through it like I did, actually, rather easily, just a few hot flashes, some sleepless nights, but some are truly suffering. But here, that's the myth. Don't take it unless you're truly suffering. So help us out with that.
So I don't really think that anyone should just suffer. I mean, I think this is a perfect place to emphasize the need, to really talk to a great healthcare provider to talk about some options. But there are some reasons why waiting may actually be a negative. So first of all, the fact that you're having hot flushes can indicate, there's been a lot of studies that have shown that having hot flushes correlates with cardiovascular disease. And having hot flushes increases stress, and stress increases cardiovascular disease and increase in inflammation. So there are some reasons why treating and alleviating the symptoms may not only be beneficial for the way you feel, but also in the long term. And that it, again, heart disease, by going on estrogen early, we can actually have a preventative effect. And I'll share a slide in a minute. And also for bone loss, for decreasing the incidence of bone problems. Just like you saw, you didn't have any symptoms, so you didn't go on hormone therapy. And then later on have, a bone loss. So I think that's a perfect example. If we could pull up that slide, I'll show you the cardiovascular information. And again, this is another positive. This is something that we learned from the WHI, because remember, they had some patients were in the early menopause. They were between 50 and 60. They were within 5 to 9 years of their menopause, and they started estrogen early. And when they did, they actually had a reduction in heart disease. And this slide is the yellow window, and you can see there was an 11% decrease in heart disease. However, in the patients that were older, they were 60 to 70, say, they were 10 to 20 years from their menopause, and they started hormone therapy. This actually had a negative impact. They actually had a worsening, 22% of them got worse and had heart disease. And the last category, which is more than 20 years. So these are people that would be 70 and above and initiating treatment. They definitely had an increase in heart disease. The picture on the right in the corner shows you what this might actually translate. These are just pictures of blood vessels. So if you have a very clean artery with no plaque, no buildup, and you start estrogen treatment, you're probably going to be decreasing the chance of developing plaque. However, if plaque is already there and there's a lot of inflammation around the plaque, and then you start estrogen, then the plaque can release, and that can increase heart disease. You can take that away.
Dr. Margaret, how do you know when it's time to go off of HT if you're on it? I mean,
case by case, we keep every year.
The HT is making you feel good, right?
Yeah, I mean, every year.
The hot flashes.
What I do is every year reevaluate and talk to patients and see how they're feeling. Sometimes I might even try reducing the dose a little bit after they've been on for 3 years or 5 years, and reduce the dose a little bit. If the flushes come back, you went too low, and then you go back. And there are other symptoms that we look at: hot flushes. We look at not sleeping. Memory is a big area. If you're going to treat, you want to treat early. So that's another area when you can't remember the noun, you can't remember what you're going to say, what you want to say. Whereas when you take estrogen, the nouns come flooding back into your brain. It's sort of a miracle.
Raise your hand if you've experienced that, everyone. Yeah.
I'm going to raise 2 hands.
And we've had very good studies actually on the cognitive function that shows it only works when you take it early, which is interesting, that within the first 5 years, you can improve the cognitive function. And if you haven't been on estrogen, you actually start destroying those brain cells. So the memory issue is very important to start early.
Before we get off this topic, Dr. Lila, is there, how do you, if you're taking progesterone, how do you, if that's part of your therapy, how do you ease out of it if you want to stop, start taking less of it? How does that work?
And that's very individual. In a lot of women, we only cycle the progesterone. If they're on a reasonably low dose of estrogen, we might only give them progesterone, not every day at all, but every 2 months, give them progesterone. And if they've had any buildup, then they might have a menstrual period, which some women, of course, hate. But if you have 6 a year, or sometimes we get it down to 4 a year, it's not so terrible. So that's one way to lower your dose and lower your time of exposure.
Oh, thank you for that. And also, I'm curious, I'm sure everyone else is too, what is the difference between progesterone and progesterone?
Mm.
Well,
Is there?
we now have close to natural progesterone, which is micronized progesterone, and we use that much more. There haven't been any big studies, certainly not 20,000 women studies on progesterone, but there have been some small studies using the micronized progesterone and showing that it's definitely less harmful, causing less side effects than the actual one. But we really do need
More research,
a better
Yeah.
protection.
Sounds that
We
way.
have one, and we're hoping to get it back. But we manage by using lower doses and more natural progesterone.
Thank you. Thank you for that, for a little clarification. You know, some of the most common menopause symptoms, everyone, I said it before, are temporary, even if they last a heck of a lot longer than you would like. You know, we're talking about the hot flashes, mood swings, maybe some sleepless, sweaty nights. But there are other things going on inside our bodies when our, levels of estrogen fluctuate and then finally drop down to their lowest level, which means you are then, postmenopausal. There's a lot going on in there. And for me personally, and Dr. Margaret, Dr. Lila know this, this is my greatest interest in all of this, because I know when you say the word menopause, women say, or anyone will say, hot flash, the first word that comes to mind. But you don't think about your heart, your brain, what's going on with your bones, because it's all inside and you don't see it. You don't see what's happening. So this is really, really important information. So, okay, so, fluctuation of the estrogen drops down. Dr. Lila, please tell us, how does these changes that are taking place in women's bodies, how should that impact how they view HT and whether they take HT or not? Because HT is normally for those more, temporary symptoms that will eventually go away, that I call the terrible trifecta. So can you help us out with that?
Again, I think it's to individualization. Even Joanne Manson of the WHI, when she wrote her saying our benefits outweigh our risks, I think that's a way that a good healthcare provider who really understands menopause and is up to date on all the science of hormones goes over it. So we go over each individual risk, each individual benefit, and you're absolutely right. The bone benefit and the heart benefit and the brain benefit for most women will shine out above any risk. But you have to go over the risk, as Dr. Margaret said. For example, if you have a clotting risk, it's certainly something that we count. And I think that's why I feel women have to, at least in the beginning when they're in menopause, really have to see a healthcare provider who really knows about menopause. And they're getting harder to find, but they're out.
Yes. Yeah, absolutely. And we'll get to that actually a little bit later. But okay, myth number 7. Very, very hot topic, I think, for a long time, especially since there are quite a few celebrities out there in the world who like to talk about them, bioidentical hormones. So here's the myth. Bioidentical hormones are safer than FDA-approved hormone therapy. Dr. Lila, there is a perception out there that these hormones are natural and then others are not. Just help us out with this. Bioidenticals versus hormone therapy as we know it.
I think it is important to straighten this out. And the words bioidentical is actually a manufactured word. None of them, somebody has a mic open that keeps going. Could you check it out there. So Bioidentical was made up. None of them are bioidentical because to be bioidentical, they'd have to come from the ovary. So they started interpreting, it was really a marketing tool, saying that those that are made in the back of somebody's drugstore and not FDA approved is bioidentical because it's from plants. So it's not bioidentical. And we have many FDA approved products that are made from the same plants. They're often all made from plants that are the same, and that you cannot squeeze a plant and get estrogen out of it. You have to chemically extract it. So there's none, I don't care what plant they're made from and how clean the laboratory is where they're making it, where you don't chemically extract it. So that's a fallacy. And this is another place where everybody agrees. The FDA has said, the North American Menopause has said, the Endocrine Society has said, don't take those non-FDA approved hormones, even if they're called bioidentical. They're now mass produced. They're not individually developed for women who say allergic to a certain pill or a certain pad. So they are not safer, they are less safe, and they don't have quality control. Every FDA...
That's a big issue. They don't. I've seen that over and over again, heard many experts say that.
Every day they have to do quality control, every single day, and make sure what you're getting is exactly the same as what you were getting the day before. There's no quality control. Again, that's another topic, but it really is a political issue, how they got that approval. But they have absolutely no requirement for it. And they don't have package inserts. Now, the package insert for estrogen is often not scientific. They tell you risks that don't really exist. For example, on all vaginal estrogens, they talk about side effects that only come from systemic ones. Dr. Margaret made it clear that it's different. We use very low dose. They only are absorbed locally. The vaginal products do not get in the bloodstream, and yet they have the same package insert as systemic. But still, it's good to have it to be able to talk to the healthcare provider about these issues. Oh, should I worry about this? It says estrogen might cause. But with the over-the-counter ones or the commercially non-FDA approved ones called, quote, bioidentical, but not, they don't have any package insert, no quality control.
I'm always amazed by the number of celebrities that hawk bioidenticals and try to make it cool. And there are quite a few women out there who do follow their advice, which is unfortunate since they're not medical experts, but there you have it.
Well, one thing I just want to mention
Dr. Margaret,
about the bioidentical. So FDA approved substances, but there are ways to individualize the administration of these FDA approved agents to make it feel like it's bioidentical. In other words, there are so many doses that are available. We can start at a teeny patch for some person, or I might need to go right up to the highest patch. So I'm individualizing the dose that's right for that individual. And I'll go by how their symptoms are and how they're feeling. And sometimes I'll get a blood level. Sometimes I'll actually measure a blood level and see how high the estrogen is and how much is getting absorbed. So we're making it bioidentical in a sense. We're making it treat what the person needs. And, so some people are on patches, some people are on pills. One thing I don't think we even got into was the differences and the unique differences between taking a tablet and taking a patch.
No, I was just going to ask you, Dr. Margaret, as a follow-up.
I mean, the big difference, if you're taking something orally by mouth, it has to go through the first pass of the liver, and it is released. And it turns out for hormone therapy, for estrogen, that when it's taken orally, actually has a higher risk of a blood clot than if it's taken transdermally through the skin, whether it's in a patch or through a cream or whatever transdermal approach that we have. So that's one benefit. If I have somebody that is at a high risk for a blood clot, or I'm particularly worried about, then that's someone that I'm going to deliver the medication differently and try something transdermally. If there's someone that absolutely has an allergy to contact, then that's someone that might take something by mouth. So we try to really stress these individual differences when we're giving hormone therapy to the person. So that makes it, in a sense, bioidentical. It's just using medication that's been made by a FDA approved company.
FDA approved.
Right.
Right. Thank you for clarifying that. That's great. Both of you are huge proponents of individualized medicine, personalized medicine. And so therefore, in order to do that, a woman really needs to find a healthcare provider who will be her partner. I mean, you two are exceptional and at being that partner to all of your patients, but not everyone has you. And that's unfortunate, but that's the reality. So help us out. Help us by giving us some ideas how women can find an ideal healthcare provider. Where do they look and what are they really looking for?
Well, I think going on to the North American Menopause Society's webpage and looking at, because they have people all over the country who specialize in hormone therapy and for menopause. And estrogen is not right for everyone. It might be the answer, but it might not. And just as you said, this really taps into all fields. So there may be a cardiologist that would be right, or a psychologist or a psychiatrist, or it just spans every single field. And so, I think it's helpful, get good exercise, sleep well, eat well. Being in menopause is a great time to really get healthy and do other things that can help take care of the symptoms in addition or in lieu of hormone therapy. I think the big thing is just really, trying to do what is right for you.
In partnership with a healthcare provider.
Absolutely.
I cannot underscore that enough. I know that was a big help to me personally. We have run out of time, which is so sad to me, but hopefully to be continued. Doctors Lila and Margaret, thank you so much for your leadership in everything that you do with your patient care and advocacy and training and teaching other doctors to be better doctors. Thank you so much. And again, thank you, Let's Talk Menopause, for presenting these talks to help women have a better journey through midlife and beyond and through menopause. And thank you, everyone, again, for taking time out of your incredibly busy days to spend a little time with us. We hope you learned something new today to help you on your own personal journey. Now I'm going to hand it back over to Jessica. Thank you.
Yes, I just want to reiterate what Barbara said. This was an extraordinary menopause talk for all of us, and we greatly appreciate your time. There were a lot of questions. We encourage you also, we will send a recording out of this to share it widely. And we also you can go to our website at letstalkmenopause.org to find prior talks as well. Thank you.
Thank you, everyone, for listening. And thank you, Barbara.